Today we'll go through the biological effects of corticosteroids. Here are the learning objectives. After this session, you will be able to describe the biological effects of corticosteroids, predict the consequences caused by abnormal secretion of steroid hormones. Let's start with a case. Miss Lin is a 26-year-old patient with Cushing's syndrome. She has weight gain, a round moon face, a buffalo hump, fatigability and weakness, abdominal strain, increased body hair, acne, and irregular menses. Other findings include hypertension, hyperglycemia, and an adenoma in her right adrenal gland. Questions: what causes each of these abnormalities in Cushing's syndrome? We'll answer these questions as we discuss the effects of corticosteroid hormones. The adrenal cortex secretes three types of steroid hormones: mineralocorticoids, glucocorticoids, and sex hormones. The sex hormones, female estrogen and male androgens, are produced in very small amounts, and their importance is not known with certainty. So next, we'll focus on the effects of mineralocorticoids and glucocorticoids. First, let's find out about aldosterone. It is the most abundant mineralocorticoid. The target organs of aldosterone are the kidneys. Aldosterone increases the reabsorption of sodium and excretion of potassium by the kidney tubules. It's the direct effect. Sodium ions are returned to the blood, and the potassium ions are excreted in urine. Aldosterone indirectly contributes to the maintenance of normal blood pH, blood volume, and blood pressure by promoting water retention. Please review the effects of aldosterone in Chapter 7 and Chapter 8. Hypersecretion of aldosterone, known as aldosteronism, typically results from adrenal tumors. Aldosteronism produces hypertension and edema due to excessive sodium and water retention, and hypokalemia due to accelerated excretion of potassium. If potassium loss is extreme, neurons become unresponsive, leading to muscle weakness and eventually paralysis. Mineralocorticoid deficiency causes severe renal sodium chloride wasting and hyperkalemia. Total loss of adrenocortical secretion may be fatal within 3 days to 2 weeks, unless extensive salt therapy or injection of mineralocorticoids is administered. Without mineralocorticoids, potassium ion concentration of the extracellular fluid rises markedly. Sodium and chloride are rapidly lost from the body, and the total extracellular fluid volume and blood volume become greatly reduced. Diminished cardiac output soon develops, which progresses to shock-like state, followed by death. Now let's talk about glucocorticoids. Glucocorticoid hormones include cortisol or hydrocortisone, cortisone, and corticocortisone, but only cortisol is secreted in significant amounts in humans. As with all steroid hormones, glucocorticoids act on target cells by modifying gene activity. Cortisol is secreted in response to physiological stresses, illness, physical injury, hemorrhage, fear or anger, exercise, and hunger. The primary metabolic effect of cortisol is to promote gluconeogenesis. That is, the formation of glucose from fats and proteins. Cortisol increases gluconeogenesis for energy and decreases the use of glucose. This is called the glucose sparing effect. And it is important because it conserves glucose to be used by the brain. Glucocorticoids are essential for survival during fasting because they stimulate these gluconeogenic routes. So, you can imagine that hypocortisolism would result in hypoglycemia, while excess glucocorticoid would produce hyperglycemia. Cortisol enhances the sympathetic nervous system's vasoconstrictive effects. It is necessary for the maintenance of normal blood pressure and plays a permissive role in the arterioles by upregulating alpha-1 adrenergic receptors. In this respect, cortisol is required for the arteriolar vasoconstrictive response to catecholamines. From above, you can infer that hypocortisolism will lead to hypotension, and excessive cortisol will elevate blood pressure. Cortisol inhibits bone formation by decreasing the synthesis of type 1 collagen, the major component of bone matrix. Cortisol also reduces formation of new bone by osteoblasts and decreases intestinal calcium absorption. Excess cortisol results in osteoporosis, which is a major side effect in prolonged steroid therapy. Cortisol impedes the release of histamine and serotonin from mast cells and platelets, and also stabilizes lysosomal membranes. Cortisol blocks the production of interleukin-2 and the proliferation of T lymphocytes, which are critical for cellular immunity. Exogenous glucocorticoids can be given therapeutically to suppress the immune response and prevent the rejection of transplanted organs. Too much cortisol, however, decreases the immune response. Normal cortisol secretion limits the inflammatory process to only what is useful for tissue repair and prevents excessive tissue destruction. Excessive glucocorticoids reduce inflammation by decreasing the release of inflammatory chemicals, depress the immune system, leaving the body susceptible to infection, and significantly slow down tissue healing. Glucocorticoid drugs can control symptoms of many chronic inflammatory disorders, such as rheumatoid arthritis and allergic responses. However, these potent drugs are a double-edged sword because of their undesired effects. Transplant recipients or people with rheumatoid arthritis or severe asthma who must take corticosteroids for prolonged periods may exhibit any of the above-mentioned side effects. In such cases, the disadvantage of this medication must be weighed against the benefits provided. Meesmann-Cushing syndrome is the result of hypersecretion of cortisol. The cause may be pituitary tumor that increases ACTH secretion, or tumor of the adrenal cortex itself, as in this case. Excessive cortisol promotes fat deposition in the trunk of the body, while the extremities remain thin, so-called centripetal obesity, and buffalo hump, which refers to the fat deposition in the interscapular area. Similarly, fat accumulation in the face produces the characteristic moon face. The skin becomes thin and fragile, and the healing after injury is slow. The bones also become brittle because osteoporosis is accelerated. The irregular menses and acne are due to the increased adrenal androgens. Patients with insufficient cortisol secretion fail to maintain normal blood glucose between meals because they cannot synthesize significant quantities of glucose by gluconeogenesis. Furthermore, lack of cortisol reduces the mobilization of both proteins and fats from the tissues, thereby depressing many other metabolic functions of the body. Even when excess quantities of glucose and other nutrients are available, the patient's muscles are weak, indicating that glucocorticoids are necessary to maintain other metabolic functions of the tissues in addition to energy metabolism. Inadequate cortisol secretion also makes a person highly susceptible to the effects of different types of stress, and even a mild respiratory infection can be life-threatening. Addison's disease results from the inability of the adrenal cortex to produce sufficient adrenocortical hormones. Symptoms include hyperpigmentation from excess pituitary production of alpha melanocyte-stimulating hormone, hypotension, hyponatremia, hypoglycemia, hyperkalemia, mild acidosis, decreased cardiac output, muscular weakness, susceptibility to infection, etc. Corticosteroid replacement therapy is the usual treatment. That's all for today. Thank you.